to know the exact calculation formula, but there should be a good understanding of how it is linked. And it should also be clearly specified what share of the funds are actually linked to performance when they are received, so that it can be seen. To increase the timeliness of disbursements, we suggest to speed up the approval of the performance-based budget allocations by starting the verification process earlier. That would also allow the side agreement to be signed earlier, and here the discussions could perhaps start earlier as well. And then we suggest to form a small working group, including the Ministry of Health, BORA, the Treasury, to identify and agree how timely disbursement can be ensured and where the delays may be in the process from enough funding is available in the holding account to they reach the LGA level. We suggest to appoint, or we recommend to appoint an HPA focal point in the Ministry of Finance to ensure consistent participation at an adequate level in the various committees. That would hopefully improve the process and contribute to improving the process in many ways. And then, in view of the additional workload caused by these two innovations, and also to allow for more follow-up analysis and proactive information sharing to actually strengthen the HPF Secretariat. Thank you.
Thank you very much, Ulrika and Dr. Njau. Although Dr. Njau, you didn't speak, we heard your voice through Ulrika. And, but you can greet the people. Dr. Njau, can you say hello so that your voice is heard? Can I have the chairs for all of the presenters now of this today's session? I want you here in front, and you are going to receive some questions. Can we have lights on? Where was the switch? I don't see everybody. Okay. So we had a marathon presentations. Now we are going to have discussions, and it's not question and answers. It is discussions, and our discussions should lead us to two things. We have heard of where we are in terms of the analytical review. We have heard from the MTR review what was the reasons for those findings, and we have heard from the basket team a review how the financing works. Now we want to see two things. Either these things have not been going well, yes, so what can we do in the remaining period of HHSP4? So you come forward not with a question, but with a question and an answer yourself. Then the second one, you can say, these are not yet done, but they have to be done, so this is how it should appear in the HHSP file. So we are already starting to discuss. It's not answering or verifying the data now and whatever. If there are questions about the verification of the data or whatever, we can give that to the team, they'll work them on. But I wanted the discussion to be fruitful and to bring things forward. So the team come forward, I'll give you a chance to answer. We also have our older elderly leaders here, we'll give also them some time to speak. So, how do we start? Do we go open for all, or do we? Okay, so I will have hands, and then, if you are the first to raise the hand, of course you'll be the first. Chiho, I've seen you. I've seen the elders there. I've seen your hand there, so I'll start with those, okay? I'll start with those, and so Chiho, you go first, then you come here, then there, please. Can I have mics? Give to you.
Thank you very much. Thank you very much to both teams, because this, I know, was an enormous undertaking. And then particularly for the HSSB 4, I was part of some of the consultations and the August meeting, and I could see really the pieces have really come together really nicely. So I wanted to first start off with a word of thanks for pulling all of this together and presenting information I know it's been difficult because I know there's a lot more to share and yet the time is limited. I wanted to just start off by just a few thoughts for consideration. The first one is we just had a joint multi-sectoral nutrition review meeting last week in Dodoma, where the midterm review of the National Multi-Sectoral Nutrition Action Plan was completed. The report is basically done, and there's a lot of things that came out of that MTR, which I think will need to be linked up with this, because there's a lot of health sector responsibilities that emerged in the MNAP MTR that I think is very relevant to the remaining period of HSSB 4, but also HSSB 5 going forward. And some of the key things that emerged, I think, came up here too. The reason why I bring this up is the MNAP MTR, because it was very much nutrition-centered, had specific set of recommendations that emerged. I think, but both teams linking up would then benefit the health sector as a whole in coming up with very succinct, focused set of recommendations in addressing chronic malnutrition among underfunded. Coming out here very strongly is that the context has evolved very fast in the last several years. So now we're at a point of dealing with the unfinished agenda of the communicable disease and then the stunting among children, but then the emerging need for, we also talked about the obesity, the blood pressure, the cardiovascular disease component of it. And it was Deputy Minister who was at that JMNR meeting who said that the ministry is launching the initiative on NCD. So we're dealing with that, and at the same time, there's the whole adolescent agenda that we haven't quite fulfilled during this HSSB 4, but we know for sure that's something that needs to be really punctuated. So what I'm trying to say here is we're asking the health systems to become much more dynamic and probably much more flexible given the needs of the people with much more expanded disease portfolio. And so I'm wondering, as we look at and thank you so much for very comprehensive observations and findings from the field, and I'm wondering as we work together to come up with a specific set of recommendations for the remaining period of HSSB 4, and to guide our thinking going into HSSB 5 focus areas, I wanted to kind of go back to sort of the system, I guess the WHO system blocks of, sort of parceling them into, I don't mean to pigeonhole them, but like thinking from the service delivery part, which we know is going to be very diverse, much more diverse than the health system so far has dealt with. And then what does this mean for workforce, the skills, numbers, all of that. So that was the second point. The last point I wanted to make was on gender. I hope that we could all work together in the recommendation sessions to make sure that it's kind of part and parcel of all of these aspects. That it isn't also not just about the women and girls. I think it is also about men who may, but particularly I'm concerned about the adolescent boys who probably are reluctant to seek services and yet may need to be doing this. How is the health system able to respond to those needs and the older men as well? So I'll pause here, but these are just food for thought and suggestion as we work together on a concrete set of recommendations.
Okay. Thank you, Chiho. You are the first and you are a lady, that's why I let you go on. So, but I would like we do as she has done, but just be me point more directly. I'll start with Dr. Ingora first.
Thank you, Dr. Ipuge. In the interest of time and fairness, I'm going to speak only on one issue. But I can't help the feeling, having left the ministry 10 years ago, that I was in a state of deja vu. Like I was there. The same things are being repeated, but in a different way. And I have a feeling if this particular meeting does not address the issues, instead of just discussing them, next time we'll be repeating exactly what we talked this year. Now, having said that, I'd like to dwell on only one issue. It has to do with the human resources, but in relation to leadership and management at the district level. We all know teams function with proper leadership. We can have a lot of people in a team, but if the leadership is lacking, nothing moves. I have seen districts that virtually collapsed under one DMO and suddenly get rejuvenated in the next 2 years because a new DMO arrived. And immediately when the DMO left, the whole thing collapses again. Now, having said that, we all know there is a very high turnover of DMOs. We cannot help it. And a lot of medical officers go to the district because they know it is a prerequisite for postgraduate training. Otherwise, they would have opted not to go to the districts. So they go there for 2 years, and then they disappear into postgraduate training and never come back to the districts. So every 2 years, we have a new DMO. Some of them know why they are there. Some of them do not know. They finish their time, they leave. So in the past, we had a specific program for those who showed promise to be trained in Masters in Public Health. Where is that program today? Do we assume all DMOs are managers? Or do you think they will learn on the job and when they know what to do, they disappear after 2 years? There was even some discussion in the past which never materialized. Why don't we make a DMO post a professional post? Why don't we have professional DMOs who train to become DMOs and stay in the district as DMOs? And the exemplary ones become the regional medical officers. But today we're just trying by saying, this guy will work, this guy doesn't work. So let's look back. After all these years, can we rejuvenate the post of district leadership to become a professional post? So that we have DMOs who are committed to districts, who will do it continually, whether they are in district X, Y, or Z, without having to think that they will leave one day because it was a punishment post. So let me plead to this meeting. Let's look at the issue of leadership, which is so important. Otherwise, we'll keep on repeating ourselves year in, year out. Thank you.
Thank you very much, Dr. Ingora. Can I have the one from the back?
Thank you very much. I'm Dr. Elisha Osati, the President of Medical Association of Tanzania. I'm also working as a physician at Muhimbili National Hospital. So I have, as a President of Medical Association of Tanzania, as we are dealing with, we are seeing the patient on the ground. So there was a presentation that showed that the attendance, antenatal clinic attendance in some regions was 80%, and in others was 50%. And I was asking myself why in other regions 50%. And we normally knew that, of course, there was probably professionalism issues with our health workers in the district. So was that also the reason for this? And I think we also need, apart from all these things, infrastructures, and we have also to talk about the professionalism. And we should not forget that it's also a very important part in the healthcare delivery. But again, on the issue of insurance, it was said that in 2016, the data that was presented, the coverage was 9%, and with CHF it's 32%. This is just to ask, because we have been talking about the single health insurance, and you know that there was a bill that had to be presented in the parliament, so to have the Single Health Insurance Act. Where is it now? And because we think will be one of the solutions for our problems here, especially in coverage, because when you are attending a patient with health insurance, you are at least comfortable that you can get some care. But again, talking about there was a presentation of that, the data on the shortage of healthcare workers, which went up to 50%. And we are asking ourselves, of course, we know this had been there, but can we have innovation? I know in July we had some kind of discussion on this here in Dodoma. So can we have a model, something like what is happening, for example, at MUHIMU National Hospital or JKCI? After the interns have finished their internship, they will retain some of them as either extended internship program, and they will pay them by the internal generated funds. Can the RRH also come up with that innovation so that it becomes a short-term solution for shortage of healthcare workers? But the last thing, we talk about the training in our health institutions, and there is a shortage, a critical shortage of teaching staff. And we should ask ourselves, why is it like that? Because, you know, we have our senior colleagues who have been there for almost 30, 40 years as professors. So why didn't they, mentor or supervise the young generations to take care? Because, you know, for example, in some of the institutions currently, there is a very severe shortage. Even it reached the area that even the institution has lost its memory because the old generation have gone and nobody else take their part. So I think PS is here as the part of government. I think you can also take the recommendation to the Ministry of Education probably for the professor to be maybe promoted, something like that. They should have the junior colleagues that they mentor within the departments, because we have a lot of teaching students that there are no junior colleagues to take part of those who have gone, who have retired. Thank you.
Yeah, I have seen you. I have seen you as well. Seen you. Just hold on.
Yeah, thank you very much, all contributors, all presenters. May I live to hear that we have the new concept of One Health, and I would like the health sector strategic file to accommodate the One Health concept. There are emerging diseases and re-emerging diseases, the zoonotic diseases, and therefore I think the health sector should be responsive to other sectors, or like accidents and whatever. So maybe the main speakers, I think they will respond on this, how we can improve the health sector, be responsive to other sectors as a One Health concept.
Madam Chairperson, you will excuse me. Sangine nitaongea Kiingereza, sangine nitaongea Kiswahili. Nitaongea vitu vine tu. I will talk about 4 items ambazo my heart really bleeds, is bleeding. One, I would like to congratulate the ministry on having SWAP. It took us very long to have SWAP. And we can write books and books and books on it. After having said that, I want to talk about the 50% personnel. And basically, when you said you had just a few posts, you advertised, and you had thousands of applicants, which means the people are around. The people whom you would have needed are around somewhere. Well, even if we had it, we had enough schools to synchronize and invest in our training versus our deployment. But currently, I'm sorry, I don't have soft words. I failed in diplomacy. Our training is an investment, and it's a heavy investment, but our deployment is very poor. That's why we are having this deficiency of 50%. In the remaining part of the 4, HSP 4, let's look how we can harvest better the investment we've made in training. My second issue is, someone mentioned, well, the health workers and the health service is very inhuman. He put a sword in the lung with that statement. Is my ethical training failing? Is my supervision failing? Or what is wrong? I mean, how do we expect this client of ours to come up to our units with 50% workers who are mistreating me? I will look for another alternative. Takwenda kwa Mohammed. So we should actually fill the 50% deficiency, because that one will fill up the other things. We should seriously do supportive supervision and ethical ethics. We should look into the ethical ethics. The third sword in the stomach was when you build a unit when there is a unit there. Mtu wa public-private partnership amesema unit ya serikali iko hapa, unit ya askofu iko hapa. Na zamani tuliwaambieni no confrontation, complementation. Mimi askofu kweli nitawaamini nyinyi, nifanye complementation wakati unit yenu iko adjacent. Mtanipa mimi support kweli wakati unit yenu iko hapa? Utamnyonyesha mtoto wa jirani wakati una mtoto? Yani hii tunavunja undugu hii. Tuangalie tena upya hii in the coming HSP4. Ya mwisho namuona facilitator anisogea. Ya mwisho, kuna unit hapa imesema, well, nataka kuwakumbusha tu kwamba tulianza MPH course. Iko wapi? Kuna wakati tumetrain RMOs, DMOs, SEDA. Iko wapi ile course? Hiyo nitawaacheni nyinyi wenyewe wapangaji, mtatupa jibu. Lakini ya mwisho ni kwamba mmeongelea juu ya multi-sectoral collaboration. Mimi nakubaliana na nyinyi kabisa katika hilo, kwamba ministries zote zishirikiane. Nakubaliana na nyinyi kabisa kwamba kilimo, viwanda, nini tushirikiane. Hata matangazo tushirikiane. Kuna tangazo sasa, kaka yangu unataka nini kaka mkuu? Mayai mane, zege, mayai mane, nikatie karoti na madikodiko mengine. Sasa nauliza, tangazo lile, is it in favor ya NCD? Maana mjukuu wangu mimi anaangalia, anamuona mtu pale anasema mayai mane, karoti na madikodiko mengine. Najua wale madikodiko mengine hata jua, lakini walao mayai mane amesikia. Kwa hiyo naomba sana hii statement mlioisema leo hapa ya ministries na serikali na nini kushirikiana is important, kwamba wizara moja isitoe jambo ambalo litaua efforts ya idara ingine. Lakini la mwisho, munisi, we munisi mzee mwenzangu, ulikuwa unaniuliza maswali wakati fulani. Leo nataka kukuhoji our partners wena wakujua si tunahamia Dodoma. Lakini hata kama walijua, kwani si tunahitaji watu wangapi kwenye mikutano yetu?
Ingekuwa kutoka Dodoma kwenda Dar es Salaam ambako kuna beach, wala isingekuwa tabu. Lakini kutoka kwenye beach kuja Dar es Salaam kuja Dodoma, tabu. Ninachotaka kusema hivi, wao wangetoa mtu mmoja tu. After all, sisi tunayefanya naye kazi ni mtu huyo mmoja wa afya, who can come and interact with the government. Halafu angeripoti kwake kama anavyokuja kwenye mkutano wote Dar es Salaam, anaripoti kwenye ubalozi. Kwa hiyo mimi sitaki kusema kwamba, usinielewe vibaya, sisemi kwamba hawana nia ya kuja Dodoma. Najua kabisa wana nia ya kuja Dodoma, lakini kwa kuanzia wala wangeleta mtu mmoja tu ambaye ange-interact na serikali. Asante sana mwenyekiti.
I was so lucky. That was the shortest Dr. Ukunda can speak. So that was the shortest. I'm so lucky. Can you have on the call? Thank you, Dr.
So changu kumbe kubwa. Moderator, kwanza naomba niseme kwamba civil society organizations baada ya kuwa tulipata program. So a presentation from civil society organization that we had prepared with issues and recommendations. Because the new timetable doesn't allow that, I request that we submit that presentation so it goes on record as civil society input.
In writing, okay, you are submitting the paper. No, you are not making the presentation now.
Not now.
Okay.
Not now.
So, you submit that.
The first issue, Dr. Lea Maliza ameongea vizuri, but I wanted to say, tunaweza kuvuna kama tujapanda. And I think we are cheating ourselves. Ukiangalia graph ya mid-term review, it shows the health sector staff is going down. We expect the performance to go up. I'm not sure whether the ministry responsible with the money is here, but I wanted to say this is one of the most urgent action as you directed that I think we need to work on, and I mean urgent, so that we can harness and harvest after we have invested in human resource. Secondly, on the SWAP structure, civil society are being organized at national level, and we wonder what is the form of engagement in SWAP at regional and district level. The next part that I think we need to work on is having SWAP that is decentralized. The third area that I wanted to recommend is on the urban-rural dichotomy and inequality. The data shows that in the rural areas, the core coverage indicators iko chini sana as compared to the urban areas, which means that since most of the people live in the rural area, then we need deliberate effort in the plan to make sure that we reach the most rural areas, so that we can reach more people who are living in the rural areas. The last point that I wanted to make is also related on investment, the finance in health. We have, from the review that are pending, is $35. It has remained there. Maybe what health spending is, instead of a social spending, understanding that it's an investment. And once we begin understanding that spending in health sector is an investment, then it will not have allocations going down and having 2 last quarters dispersed on the quarter again. Because we are compromising the quality of work, but also the coverage that we could have if we had dispersed money on time. Thank you.
Thank you very much. So you'll submit your statement, and maybe next year you can harmonize like the FBO and private did. They discuss and have one presentation. So the CSU and the NGOs, you should also do the same, so that because having too many opening statements also, you could see today how it went. So it's better to have fewer but comprehensive. So, but that instruction will come from there. It's me as an advice. Okay, I've seen you.
Mheshimiwa Mwenyekiti na wajumbe wa mkutano, marehemu baba wa taifa alikuwa na ndoto ya kupiga vita adui watatu: umaskini, ujinga na maradhi. Mkutano wako mwenyekiti wa 20 wa mapitio ya utendaji wa sekta ya afya umeenda sambamba na sisi tunapokumbuka miaka 20 tangu baba wa taifa aondoke. Mkutano wako mwenyekiti umedhihirisha kwamba sekta ya afya tumemwenzi kwa vitendo marehemu baba wa taifa. Performance ni nzuri sana mwenyekiti. Tuna kila sababu ya kujipongeza. Inawezekana isiwe 100%, lakini kazi kubwa imefanyika for the past 20 years. Hongereni sana wana sekta ya afya. La pili, Mheshimiwa Mwenyekiti, ni sera ya afya. Sera ya afya tuna taarifa na tumeshiriki katika kufanyia mapitio, lakini ushauri wangu ni kwamba mapendekezo basi yatakayotolewa katika mkutano wako huu yakaainishwe na kwenda sambamba na matamko ya sera mpya ili yatekelezeke katika kipindi kingine kijacho. Yapo ambayo tungependa kuyatamka hapo mwenyekiti. Moja hapo, inawezekana tusijue kwamba sera mpya inasapoti nini kuhusiana na swala la, labda niende tu specific. Imetolewa taarifa hapa ya unmet needs za family planning. The gap is so huge. Inawezekana kuna multiple factors zinazoendana na upatikanaji wa commodities na choice ya methods. Je, ni innovations gani ambazo sera ya sasa inazikubali ili kuspeed up access ya family planning commodities? Niko privilege hapa, nina viongozi waliokuwa viongozi wangu, waziri na CMO wawili. Inanikumbusha kipindi ambacho nimefanya kazi Mbeya. Tulikuwa na project kubwa sana ya family planning under EFYD support. Na hii ili triple family planning percentage at CPR levels mara 3 katika kipindi cha miaka 7. Je, sera yetu inakubali tuendane na community persons ili watuongezee chachu katika utekelezaji wa haya? Tunafahamu sayansi inatueleza kwamba family planning na contributes significant to reduction ya maternal mortality. We have a gynecologist hapa watatestify hilo, lakini around 40% reduction ya maternal mortality inaweza ikatokana na matumizi sahihi ya family planning. Kwa hiyo let us be innovative to accelerate the remaining miles. Nadhani tuta-achieve kwa kiasi kikubwa. Swala la NCD epidemic limeshazungumziwa nisilitaje, lakini pointi yangu hapa ni kwamba turudi katika element za prevention, kwa sababu ina protect, ina promote na maintain health ya individuals and population, na kwa jinsi hiyo tutaweza ku overcome tatizo la non-communicable diseases. La mwisho mwenyekiti ni ombi. Ni ombi kwa sababu ilipozungumzia swala la neonatal mortality, pediatricians hapa mpo, na common causes za mortality zinafahamika. From infections, preterm and asphyxia. Kwenye infection kuna element ambayo huwa tuna tendency ya overlook, especially sepsis. Huyu anayemhudumia yule mama anayejifungua anamhudumia katika mazingira gani? We all remember the 3 C's: clean deliveries, clean hands, cold care. Yule msimamizi matron hospitali anayeangalia haya. Kwa hiyo usimamizi wa facility mwenyekiti uwe pia ni ndani ya facility, viongozi wa facility wasimamie huduma. Isije ikawa mama anashushwa pale kwenye kitanda, Macintosh inafutwa, anaingia mwingine kwa ajili ya kupata huduma ya uzazi. Haya matatizo hayatakwisha. Last but not the least, mwenyekiti, ombi sasa, naomba wizara turudi kwenye archives za wizara. Ziko interventions nyingi nzuri ambazo zilifanya kazi, lakini kwa sababu resources zilikuwa ni limited, hatukuweza ku scale up. Moja hapo ni helping babies birth kwa ajili ya kusaidia kupunguza neonatal mortality na nyingine nyingi. Kwa hiyo ni kuomba mwenyekiti utask timu yako waangalie archive kuna kitu gani kizuri ambacho kwa mazingira ya leo kinaweza kusaidia kuleta mapinduzi katika huduma za afya. La mwisho nisilisahau, nitatenda dhambi sana. Nimeangalia hii analysis ambayo inaonyesha service delivery kimkoa, na kila mmoja natamani hospitali ya ngazi ya juu ya taifa iwe the best. Sasa sijui itakuwa imejificha kwenye takwimu za mkoa wa Dar es Salaam au inaangaliwa kipekee yake, ili tusije tuka overlook kwamba tunaziangalia hospitali za mikoa, lakini hizi hospitali ambazo ndio tegemeo la taifa, hospitali za rufaa za taifa, kuna mambo yanatakiwa kuangaliwa, ikiwa ni pamoja na watendaji wa kutoa huduma katika facilities zetu ngazi zote hili, sababu tumeobserve na tunahisi kwamba kuna tatizo la usimamizi wa intense. Sababu huko field, mheshimiwa mwenyekiti, kuna maeneo yanasikitisha. Kuna baadhi wanaohitimu huduma za kitabibu lakini skills kwa kweli ya can say ni zero. Kwa this calls kwamba kuna haja ya kurudi back kwa facilities zinazosimamia interns, wafanye usimamizi ambao ni madhubuti ili anayeiva aive akaweze kujitegemea kutoa huduma kule anakotumwa. Asante mwenyekiti.
Asante. Former katibu mkuu huyo, after your comment, then we are going to give the panel to respond, and some of the responses will be from.
Thank you. Thank you very much. Congratulations on such a comprehensive review of the HSSP4, One Plan 2, and even the Health Basket Fund. I have two thoughts that I thought I would share, but I'm sure you've already thought about this. My first one is I find it very striking that it shows that in some regions with less resources than planned, better results are achieved. Looking at Kagera and Kigoma. So I would like to understand if there's any thinking about further research to understand what is underpinning this, because resources will always be constrained, there's never enough. So learning from what is making the progress happen there would be helpful. The second point I think is linked to maybe building on what the last speaker was saying. Looking forward, listening to the Health Basket Fund review, it sounds like the link to results was very helpful in focusing everybody. And I wonder if it would be possible when we look forward to the recommendations for HSSP 5 to link them to some very concrete results, whether that's access to family planning, addressing neonatal mortality, preventing epidemics, improving quality. These aspects I think will be very helpful to keep everybody focused. And then I guess my other thought linked to that is, what are the available resources moving forward? So that when this plan is developed as Health Sector Strategic Plan 5, it is linked to available resources and is something that realistically can be achieved. That would be helpful. Thank you.
Thank you very much. Let me start saying a few things, and then I will especially ask Professor Monishi and Aditya to add on governance and human resources. First of all, many of the remarks were, let's say, enriching our findings and giving more flavor to what we have said, so we will take note of that, and in our final version add some things. I think I want to stress once more that our overall conclusion is that there is progress. And I was there 10 years ago, Dr. Ingora, you remember me, and I know the difference between what we saw this time and what we saw that time. And of course some things are déjà vu, but déjà vu at a higher level. And we definitely see a lot of progress, and I think nobody should leave this room today saying that the midterm review only showed failures. No, it's definitely progress that we see, but it is important to improve. And then we come to the last speaker who said the difference between regions. I think one of the very rich parts of this review is that we did a very, very thorough analysis of data. We could break it down to regions, we can even break it down to councils. We didn't do that because of some denominator problems that were explained. But many of the issues are not simple, linear, as you saw from the different slides that were shown. Indeed, there are some regions that perform much better with fewer human resources, fewer health facilities. But as was mentioned by one of the speakers, leadership is a very important issue. If we see strong leadership in the councils and the regions, we see better performance. So indeed there is a reason to embark on that once more, on strengthening leadership. We also see that support from partners in regions who have their programs there helps. We also see that maybe some of the socio-economic factors work. So if you go through the analytic report, you see many, many different statistics and analysis trying to find out the reason for differences. But what is important to mention, first of all, one region can be very good in one area, but bad in another area. So it is not to say that one region is bad in all areas and not performing, and the others are always performing well. So we need to differentiate our targets and differentiate our priorities per region and even in the region per council. So the decentralization, if we use information more smartly and if we do better bottom-up planning and facilitate that with targeted resources, we can solve many problems that are not countrywide problems but are localized problems. So we in HSSP 5 definitely have to move into that direction. I want just to say that tomorrow we come back with recommendations that we made for HSSP 5 and we are going to discuss those extensively in groups. So I was a bit short on the recommendations today because I know that we'll come back tomorrow. So with these few remarks, there are many issues that we could discuss at length, but I assume that there are more questions. I would like to ask Professor Munishi to address the governance issue and the human resource issues.
Maybe, Jap, you don't have to respond to all, because the most important is to give the audience to say a few. So some of them you can capture, unless it's very burning that you have to respond.
Okay, thank you. 2 blocks in the WHO's 6 building blocks are cross-cutting. The first one is leadership and governance. That facilitates all the other blocks to function well. If we are doing poorly in this particular block, that may likely affect human resources for health, safety delivery, and the other blocks. So that is why it is so important. And we said, unfortunately, some of the skills and knowledge in the area of management, the area of leadership and management, so that when these people graduate to become DMOs, they have some ideas of what is going on. In my field study, I found the DMOs, depending on the health secretaries, that means they are subordinates to guide them on what to do. Okay, that's all right, but it looks like a bit awkward. So I think that expresses some gap. 2, I think I heard something. We said we need a co-production of health services, quality health services. There should not be another ministry going counter to promotion and production of acceptable services. That's why you have health in all policies, but how it can be enforced is not just a question of meetings and meetings. Why we need to have a coordinator information system and focal points in the other strategic ministries to make sure that it becomes. In that regard, I was not very comfortable if there is an environmental impact assessment. Why can't there be health impact assessment, especially when it comes to other ministries polluting the status, the health status of the population, so that it becomes, accountable. You invite investors in industry, but these investors, they can only do environmental impact assessment, and they pay the consultants. Whoever pays the piper chooses the tone of the music. That is unfortunate. But then the ministry should be in charge of making sure that if it's possible to make that policy recommendation so that you can have a health impact assessment cutting across all the programs in the ministry. I think that's the points I had to just.
Thank you. Good afternoon again. There are a lot of issues that came on the side of human resources. Maybe the first one is the issue of leadership. And we know that there is a correlation between leadership and management practices with the retention of human resources. And really, this is one is acknowledged, and I think it has to be part of the HRH strategic plan. We've been having it, but operationalizing it has been a problem. But again, there's issue of professionalism in healthcare delivery. This is also a HR issue, and we've also noticed it. You've been hearing issues on Makole, and we have noted that professionalism is declining, or if it's not diminishing. And we've seen sometimes things like nursing care is taken as, it's something that it has to happen, but in some areas now it has become as an innovation. Something that we needed to, it should have happened, but you can see when you go to our facilities, it will change into innovation now. So professionalism has to be revitalized, and there should be ways of doing that. We agree on that. And again, the whole issue of training, how do we groom teachers? We have two issues here. When it comes to universities, of course, that can happen because it has to be part of the professors. But the question is, do we have performance indicators for the professors? Is it part of their work? There are a lot of examples, for example, from Sekta model for the surgeons, that a surgeon has to groom another surgeon with a logbook and whatever, so that this young surgeon is growing and becomes a surgeon with little training. But do we have that mechanism for teachers? So I think it's something that is very strategic. It has to go into the strategies. And we've also seen, Dr. Upunda, you talked about we have to think of making sure that we bridge the 50% gap. Now we have to put more investment in deployment. And it is true, and the health sector actors, both government and non-government, have seen that. And the reason that we're going to have a high-level meeting is to try to come back and say, okay, we have been having this gap, and we've tried to bridge, we couldn't. Then how are we going to have, a unified focus on investing on human resources? But still we are challenged in this area because we are not really sure the requirement that we are making is an actual requirement when it comes to productivity. And we have to relook. We've said we need certain number of health workers for a certain level of facilities. Are the facilities the same? Do they have the same workload? So we need also to go back and try to refocus or recalculate our requirements. And also another thing that we have seen on the HR is the whole issue of induction. Dr. Upunda, you said it was done in SEDA, and you remember I was part of the trainers, but this thing died. So the issues of going to the archive and see the better things that we have been doing and putting it back into practice. And I'm sure the HR is here in the HRH strategic plan, and in HSP4, it has to be part of it. And again, the issue of urban-rural divide is there. We've seen it, and we know there are a lot of reasons about that. The last part is, why do we have areas with low HRH, but still they have good performance? I think it's something, that's the learning question. We have to go and see it. But we've also noted we have supportive supervision. But we are thinking supportive supervision is good as a periodic. But do we have internal supervision within the facilities that will trigger accountability of health facilities, of health providers to do what they're supposed to do? Thank you.
Thank you. Just a quick update on what was asked by the President of Medical Association of MAT on the status of single national health insurance. As of now, it is still within the government machinery, and we know that we had conducted the actual evaluation way back in 2016, but things have changed. So now we are conducting another one with the current data so as to determine the sustainability of the fund that we are going to form. So the work has started, and we believe in 2 or 3 months to come to be finalized. Then it will enable the machinery to make decision on the formation of the single national health insurance together with enacting the law with regards to mandatory health insurance in the country. Thank you.
Thank you very much, Konga, for that last word. I think we have heard a lot about single national health insurance. The issue is for people getting universal insurance or mandatory is better. Single is a mechanism. So thank you for that. Now some more questions, or you want to go for dinner? Dinner, more discussion. Dinner. No more questions, okay? Okay, so, is there any question? Yeah, please. One last question, then
Jamani, ndugu zangu mnisamehe, najua mtaka kwenda kwa dina. Kwa hiyo nitachangia kwa haraka sana. Mimi nilikuwa nachangia tu kama ambavyo kaka yangu hapa amesema kwamba tunataka kuvuna lakini hatujapanda. Lakini niseme pia tu kwamba kuna wakati tunapanda na kwa sababu Mungu si athumani tunafanikiwa kuvuna. Lakini along the way sasa inapofika kwenye mavuno tunaacha kile tulichopanda, tunaenda tena kuanza kitu kipya na mwishowe yale mavuno yanaharibikia shambani. Na maana gani? Katika Sekta Strategic Plan 4 serikali imefanya vizuri sana, imeshirikiana na wadau na Wizara ya Afya, NACTE na wadau mbalimbali. Ikaanzishwa kozi ya community health worker. Investment nyingi kweli zimefanyika na tukawa tunaelekea vizuri, na kwa mwaka jana tukawa tumefikia hatua mpaka ya kuwa na draft ya scheme of service kwa ajili ya community health worker. Lakini kwa mwaka huu ghafla tunabadilisha uelekeo na kutambua hata katika mkutano wa RMO na DMO ilikuwa ni kwamba wanabidi waka roll out uturo model. Sasa nadhani imefikia tunapoelekea katika Health Sector Strategic Plan 5 ni vizuri tuka concentrate wakati yale ambayo tunakuwa tumeanzisha yasiishie katikati. Kwa hiyo katika mwaka mmoja ambao umebakia, ninachoshauri ni kwamba hichi ambacho tulichokuwa tumekianza tusikiache tukikimalizie. Asante sana.
Asante mwenyekiti na asante moderator. Mimi sina swali bali ni washukuru kwanza timu hii ya maconsultant, wamefanya kazi kubwa na nzuri. Lakini nitaka kuwasaidia kitu kimoja. Katika taarifa yao kuna maeneo mengi wanasema taarifa haipo, taarifa haipatikani, na ni maeneo mengi kidogo. Kwa hiyo nilikuwa na labda na shauri kwamba tutakapoenda kwenye strategic plan 5 tuainishe kwamba ili tuweze kuassess zile target zetu, taarifa hizi tutazipata wapi, na kama hazipo katika miundo ya kawaida ambao ni kama kwa mfano HMIS ambayo wameelezea kwamba kwa kiasi kikubwa reporting ilifikia 95% and yet hawakuweza kupata hizo taarifa. Kwa hiyo ilikuwa na shauri kwenye labda strategic plan 5 basi tuainishe kwenye plani yetu taarifa hizi ili tuweze kujibu maswali mbalimbali zitapatikana wapi. Na kaposheni haka kanahusu kwamba ndio tunaangalia human resource for health kwa ujumla wake, lakini nadhani pia tungeangalia maeneo maalum. Maeneo maalum ni fanya kazi kubwa na kuna a lot of investment ambayo imefanyika, lakini moja ya taarifa ambayo tunaiona, kwa mfano tunaangalia ile impact. Je, tumeweza sasa kupunguza kupeleka wagonjwa nje ya nchi? Hatukupata majibu. Lakini yeti tuna hii taasisi yetu ya Mheshimiwa Jakaya Kikwete ambapo watoto wengi ambao wana matatizo ya moyo wamefanyiwa pale. Kwa hiyo hakuweza kupelekwa kwa ajili ya matibabu nje. Kwa hiyo nadhani tuangalie pia namna ya kuweza kupata taarifa hizi nje ya jinsi ambavyo tumetegemea hiyo mifumo. La tatu ni mfumo wenyewe wa HMIS. Nadhani Profesa Simba atakubaliana na mimi kwamba mfumo huo aliinitiate 1994. Lakini inaona bado haujaweza kuketch yani kupata data nyingi ambazo zinaweza kutupa majibu. Kwa hiyo ni vizuri na wenyewe tukauangalia. Lakini la mwisho kabisa nilikuwa naomba pia labda mwenyekiti uangalie uwezekano wa taarifa hii. Je, tunaweza tukaenda the next step? Kwa sababu ukiangalia kwenye hii taarifa tumepata data, lakini kuna zingine ni half done kwa maana ya uchambuzi. Kwa hiyo labda the next step tungeweza kufanya a bit of analysis na kupata reasons au interpretations ambazo zitatusaidia zaidi katika kuangalia strategic plan 5. Asante mwenyekiti na moderator.
Asante sana mwenyekiti. Asante moderator kunipa nafasi. Tajitahidi kuzungumza yani kwa uchache sana, ingawaje huwa napenda kuzungumza maneno mengi. My interest in maternal mortality and perinatal mortality. I assure you it's very easy to reduce maternal deaths and perinatal deaths. Very easy, but it is not possible as of today. Why? I don't know why. Because we know what kills women. Women die of obstetric hemorrhages, antepartum hemorrhage, postpartum hemorrhage, primary and secondary, and then ruptured ectopic and post-abortal hemorrhage. And we know that there are interventions for prevention and treatment, and we know what we need, what are the facilities that we need for the system to respond to the needs of these women. Secondly, women die of obstructed labor, and we know exactly how we can diagnose obstructed labor by photographic monitoring of labor. Where are the photographs? Go in the labor ward. Where are they? How can you diagnose obstructed labor without a photograph? A photograph will show you to intervene before the baby is having problems or there is impending rupture, so that you avert both the birth asphyxia, ruptured uterus, and death due to ruptured uterus and hemorrhage and sepsis. We know that women die of puerperal sepsis, either postpartum or post-abortal. But we know the risk factors. When a woman comes with the risk factors, we surely know this woman, if not well attended, is going to die, will develop puerperal sepsis, and it is going to be very difficult for us to treat it because the antibiotics we have cannot manage this case. So you can take preventive measures before puerperal sepsis develops. We know that women die of what else? Malaria, HIV/AIDS, anemia. And lucky in these fields, we have been very lucky to reduce malaria in pregnancy by practicing the interventions that are evidence-based, by preventing deaths due to HIV/AIDS, by adopting the PMTCT and the ARV, but anemia has been a problem. Why? We know what causes anemia. A woman who comes with a hemoglobin of 7 and develops a PPH will surely die, while a woman who is having a hemoglobin of 13 grams per deciliter, even if there is a massive bleeding, they will survive. Again, where are the blood banks? Where have we placed the blood banks? Why are they centralized? Women are delivering in the rurals. There is no blood bank. Specimens are sent to the zonals, but there is no reagent to test until the blood is discarded because it has expired. Why should it happen that way? And then we are complaining that we cannot reduce maternal deaths. Let me recommend one thing. Resources will never be enough anywhere. Even in the developed countries, there have never been enough resources. So we have to prioritize. Where do we? If a system can respond to maternal mortality, it is going to respond to all deaths. By the way, we are only seeing maternal deaths because we are interested to audit them. But if you start auditing all the deaths that occur in health services, you will find there is a very large number of unnecessary deaths in the hospitals. Diabetes mellitus, a perforated peptic ulcer, whatever that could be, inevitable. They are inevitable deaths. So look at that way. So I recommend you, let us look at the maternal deaths. Let us prioritize what we have. And then I'm asking about human resource for health. Where is this shortage? I don't know. Me, I don't understand. You are saying in the market there are a lot of healthcare providers who are just there, and sometimes they are volunteering without even being paid in hospitals just to get the exposure, just to get the experience. Then why don't the private sector absorb them so that the 50% that we employ in the public sector should remain in the public sector? Why should we allow our 50% human resource in public sector to go to private sector? Instead of employing more, why shouldn't we remunerate the 50% who are in the public sector more so that they stay and work with one heart, one commitment to our public? That's the question. There are a lot of things, but I don't want to talk much. But let us look this way. You know, in other countries, the obstetricians take care of pregnant women during delivery and labor, postpartum, and the neonates for 1 month. Let us recommend a change here. That obstetrician take care of a pregnant woman and the neonates to 1 month, and then hand over the children to pediatrician. Because we are the ones who tunafyatua matofali yasiyoiva, halafu tunayatupa, tunawapelekea pediatrician. Lakini zile base asphyxia tukizitake care sisi, zile kuacha kufanya siza ambazo ni za obstructed labor. Tunachelewa kwa sababu hatuoni effect zake. Tunaleta mtoto mwenye low score by siza, halafu tunapeleka kwa pediatrician. Alafu kule hatujui sisi tumetengeneza nini. Let us recommend the shift. Kama nchi zingine Cuba, Uholanzi, ambako neonates wanakuwa taken care of obstetrician. Tunafundishwa hivyo sisi. lakini katika implementation hapa Tanzania tunajikausha. Let us do that and you will see obstetrician will be more diligent taking care of women because they don't want to have base asphyxias in their hands for 1 month. Thank you very much. Other discussions will come tomorrow. Thank you.
After that passionate presentation, who wants to speak? No. Anyone? Another obstetrician, yes.
The permission from my boss, the team leader. Dr. Puge has been very instrumental when he was the head of diagnostic services and when I was the DHS. And he said, Mzee, kwa nini damu haipatikani kule to the peripheral? And then Dr. Saif was managing, mheshimiwa anakuita kidogo kama mtoto, lakini he was managing a Red Cross emergency services. So I said, why can't we see Dr. Saif and you sit down together and see how Red Cross can assist us to establish the blood transfusion services in the country so that we can serve the remotest areas. So we said, let's have zonal blood transfusion centers. And that's how we began, with the help of Dr. Sefu, Dr. Ipuge, and his colleagues. So what I want to underscore is the regional referral hospitals and the tertiary hospitals always work in hand in hand to improve some services, not all services. They are just lacking the kind of expertise around them and then innovative ideas. With regards to the human resource, we are making, but not all of us are working well, are working to a maximum capacities. Let us, as health workers, wherever you are, work as much as you can, as diligently as you can. I think we can make the difference. We can make some innovations. Let's do it that way. And then I want kuchombeza kitu kimoja. Dr. Ipioga, ni kweli unachokisema, but we need you to go down to give the ideas to those you teach. Competencies are lacking. Competencies is an issue now. There is also an issue of kuachiana madaraka au kuachiana utaalam. Succession plans. We need to have good succession plans in this country, in the health sector. Mimi Dr. Berege naondoka kama obstetrician, na mwacha nani? Ni mwachia mikono afanye kazi hiyo na moyo kama niliokuwa nao mimi. That is what we are lacking. Asante sana.
Thank you. We all started from the pregnancies, so we end there. So we'll end with the obstetricians, and I wish you a restful evening. And the secretariat, we should meet there. Others, we meet here at 7:56, because at 8 we are starting. 8 a.m. we are starting. 7:56, you are here. Hold on. Alisema maliza. Okay. Hold on.
Asante sana MC wetu. Jamani, habari za jioni. Naona inakuwa